All right, Simon Okewole, cardiac electrophysiology. I have a private group in Jackson, Tennessee, which is in the southeastern part of the state, smack dab in between Nashville and Memphis. 74-year-old female with a BMI of 16.5, so underweight. Just to kind of refresh everyone's memory, a BMI of 18.5 to 24.9 is considered normal, and anything greater than or equal to 30 is considered obese. And she was a lady that had a past medical history of sick-silent syndrome, tachybrady, as well as paroxysmal atrial fibrillation, pulmonary artery disease, thyroid disease, as well as chronic pancreatitis. Um, she presented with me to me with symptoms just worsening, fatigue, malaise, and evidence of the tachybrady on a monitor that was done. And at that point in time, we decided to go ahead and implant a dual chamber Boston Scientific Accolade MRI device. And the information about the device is there. I typically do a cut down approach using the cephalic vein as my access point. And relevant medication, she's on Eliquis, she's on Tocolo, Plavix, aspirin, prednisone. And the prednisone was being used to actually stimulate her appetite because of the issues with the chronic pancreatitis. She's underweight and had reduced PO intake for almost a year's period of time. And also she was on supplements for chronic pancreatitis. And this is just a diagram of just my, just general anatomy. We're very much familiar with that image that I've shown. All right, so this is obviously not the lady that I'm referring to, but this is pretty much the picture of my patient. And my incision is typically about 1 or 2 centimeters just below the clavicle. And the first thing that I was presented with was a lady that was fairly frail, underweight, and the area in which I would make the incision as well as insert my leads has a little bit of a divot, which is where the arrow is. And in addition to the chronic steroid use, the area is thinned out. And my biggest concern with her was risk of poor wound healing, and also just not having enough tissue to work with to allow for that area and that incision to heal well. So I voiced my concerns with her, and I let her know that, she absolutely needed the device, but one of the things that we were going to do was that I was going to use a CanGaroo pouch to add just an additional extra matrix, and also to allow for that area to heal a little bit better. For the Boston Scientific Accolade devices, they typically recommend a medium-sized pouch. My incision is, like I had mentioned, about 1 to 2 inches below the clavicle, but I tend to kind of put the pocket further down as deep as possible. I do not do a superficial pocket. And in this lady, as aesthetics was also something she was concerned about, I wanted the pocket to be and the device to be as flush as possible. And the suture sleeves were going to be kind of in the area where that divot was. And also a portion of the leads I feared would also be a little bit prominent along that area that has the divot. So rather than use the recommended size pouch, I upsized from a medium to a large, so that I would have another maybe 1.5 to maybe almost 2 centimeters to kind of play with. The size for the medium is about a 6.9 by 6.5 centimeters. Size for the large is about a 6.9 to an 8 centimeter diameter. And what I intended to do was to use that extra area of pouch and essentially kind of tack it over the suture sleeves at that level of the clavicle, so as to allow for just an added area, and also essentially just an extra barrier and allow for appropriate wound healing. My fear with the suture sleeve and also a portion of the lead was that because the area was thinned out, because the area was also hollowed out, and she also has some degree of kyphosis, that it was an increased area of lead as well as suture sleeve erosion. And using the CanGaroo pouch by itself would just kind of help create just an extra matrix, an extra layer of tissue to promote good wound healing. So, we all know the importance of the suture sleeves themselves. And we've all been involved in those cases where you have those cachectic, frail patients that just as a result of body habitus and also as a result of their anatomy, the suture sleeves become extremely prominent and could possibly erode. Because of the fact that for especially in new implants, there's a high chance of of poor wound healing post-op, and also lead dislodgement if you have a suture sleeve that is actually not anchored appropriately. I felt that this would be the best way for us to allow that area to heal appropriately. Um, I like everyone else, anchor with silk and down to the tissue in terms of the suture sleeve. And what I did with the pouch was that once I kind of got it over the suture sleeves themselves, I tacked it down to the tissue and over the portions of the lead that was just underneath my incision, and I sutured down to the tissue underneath using Okewole. I chose to use Okewole as opposed to silk to anchor to anchor the path. Because my fear was that if I used a non-absorbable silk, that area which was already thinned out, I didn't want a situation whereby the suture by itself, which was non-absorbable, could also possibly erode through that side. All right. I've used this for a number of patients who are underweight, but I've also applied this to patients who have had, the chronic steroid use, skin taper thin, older, frail patients. And this can obviously be applied not just to pacemakers themselves, but I've also applied the same approach to ICDs as well as CRT devices. And in the case of, I use probably about 95% of my devices in terms of implants at Boston. And so if I have an ICD, I'm looking at, as opposed to using a large pouch, upsizing into an extra large and essentially applying the exact same principle that I applied in terms of the pacemaker to that. Our lady had a follow-up at 3 as well as 7 week post-op, and the incision healed well, the area healed well, and that divot kind of filled in, and so she did well.
Thank you, Dr. Okewole. That was great. I just have a quick question. I'll start it off, but do you think you've been using this technique for a while now? Have you noticed that patients, don't complain of pocket pain potentially as much, or has there been any sort of correlation in your opinion?
No, I mean, for the most part, the patients don't have any issues with the sites healing. For the individuals that have the thinned out skin and have lost muscle mass, and so everything kind of sinks in. One of the big things they will complain about prior to me adopting this technique was the seatbelt rubbing up against the incision and also the seatbelt rubbing up against the suture sleeve or a portion of the lead. And for some individuals, you really don't have a lot of muscle or tissue to work with. So this approach, that I adopted, it's worked out really well, and there've been no issues or any complaints to kind of speak of. Right?
You bring up an interesting concept, which I hadn't really thought of before in terms of doing this in general. Obviously, when we use pouches, whether they be the antibiotic, synthetic Tyrex pouch, or whether it be CanGaroo, I typically don't put the lead into the pouch itself when they're redundant. I'll usually just put the can in and then tie it down or not tie it down. But similar to the case we had shown before, and I'm sure we'll talk about more, and I have some pictures later to show. I'm interested to actually hear what you guys think of that, whether that inflammatory reaction, that stuff that forms around the leads when we have to dissect them when we do generator changes, whether that would not form if we also used a bigger version of a pouch for each case and put the leads in there as well. Same concept as what we're using for the generator. I've never done that before, but maybe I should.
So I will wrap. So I will place the pulse generator within the pouch, and I will wrap the leads and put it in the pouch also, because I extract devices. And the worst thing to deal with is just the adhesions, the scarring, and also I want that pocket and I want the leads as possible to be as pristine, if God forbid, we have to do an extraction. And so that's why I started doing it. And I started doing it after I did an extraction on a patient who had an existing, I believe it was a Tyrex, and it was horrible. And because, I mean, if you guys do the extractions also, you know that if you start out with a lead that is badly compromised, that's essentially falling apart before you do anything with stylettes, before you do anything with the sheath, that is a recipe for a very, very long and difficult case. And that's why
I completely agree. I routinely adopted that practice of enveloping. I mean, you essentially want to preserve the micro environment that you're going to potentially go back in. So the way you leave it is, you at least want it to be better than when you left it, when you close the pocket. And I've seen physical, at least leads, have no fibrosis. You can see what you're doing when you're dissecting the leads. They're not adhered to one another, and you don't have to bovie them apart or use blunt dissection. And like Dr. Okewole said, you're essentially only left with what's there to remove your system. So the better situation you are when you start, the higher the chance of success when you do go to look for the inner conductor and put a stylet down to engage traction on the lead.
Yeah.
One question I had, and I was curious what everyone's thoughts were, is for thin patients, when we're worried about healing acutely, tension on the incision itself is something we're trying to avoid. So putting the device, the leads away from the incision, trying to relieve that tension is one issue. And so if you use a pouch, then you put the can, you push that down away from the incision. That's one role. But we're worried about it at the incision. And so the idea of like oversizing, so you cover both the incision and the can, the leads itself, makes a lot of sense, like you're describing.
Yeah.
I was wondering, has anyone ever tried, not using a pouch as a pouch, but kind of more of an arts and crafts project, trying cutting pieces, using extra pieces, doubling up on one side? Like you mentioned for the Tyrex, I've almost never used the Tyrex as a pouch. I use it as a, we cut it and make whatever shape sizes we want. What are your guys' experience with doing that with the CanGaroo?
I've done it once. I did it once. I had we did not have the traditional large and extra large. We did not have the medium or the large. We had an extra large, and I had an excess amount of pouch. And honestly and truly, I just cut off that excess and I put the device as I would normally plant it, just left pec side. And with the extra area of the extra pouch, I literally just took it and I just sewed it right over the suture sleeve, and I sewed it right over the portion just before the lead kind of went underneath the clavicle, and it essentially was kind of just a little covering over it. I did that and worked out okay.